I'm Jessica Steen, Associate Professor at Nova Southeastern University College of Optometry. We're going to look at two age-related macular degeneration cases. While we will highlight the important OCT biomarkers, which, if present, do increase the risk of late-stage disease, that is, geographic atrophy or macular neovascularization, our focus is really going to be on utilizing technology for the objective detection of change over time and for quantifying progression of AMD over time. This is a 72-year-old white female who initially presented because she was just unhappy with her vision. She has hypercholesterolemia and bilateral primary open-angle glaucoma, both of which are medically managed. And she also has alternating esotropia, but she is currently single with her current prism spectacles. Now, looking at the color fundus photographs, first thing first, there is clear inferior temporal and superior temporal notching of the neuroretinal rim, consistent with her glaucoma diagnosis. And if you look really carefully, inferior temporal in the left eye, there is a retinal nerve fiber layer defect. All right, now moving to the macula, we do see that there is central drusen that is associated with RPE change. Now, I do like to utilize the infrared reflectance imaging, especially in age-related macular degeneration. What we see is a greater extent of drusen than what we were able to determine with color fundus photography alone. When we look at the right eye, we clearly see an area of drusen in the superior temporal arcade, and in the left eye, drusen that extends inferior temporal through the temporal aspect of the retina into the superior temporal arcade. Even looking at the center of the fovea, we can see with infrared reflectance imaging that the area of drusen that's present appears to be much greater than what we could determine with color fundus photography alone. Now, looking at the OCT, B scan by B scan, we know this is important to either sit down at the device to scroll through each B scan or to utilize a workflow management system to be able to evaluate the imaging in its totality. What we see starting at the center of the fovea in the right eye, this is the 21-line raster, we see that there is vitreoretinal interface anomaly, and we see drusen within the center of the macula moving inferiorly. Now, if we look at just this area superior temporal that we could not identify utilizing color fundus photography, but we could see the drusen present with infrared reflectance imaging, what we see are these fine drus that are anterior to the RPE, consistent with the appearance of reticular pseudodrusen or subretinal drusenoid deposits, an important risk factor that increases the progression to late-stage disease. Often more common in females and often more common to be evaluated and to be found in the superior retina. Now, looking at the left retina, almost an identical clinical appearance right down to the vitreomacular interface anomaly, moving through with this one large central drusen. And there are other tools that we can utilize. Looking at our workflow management platform and the Retina workplace, we can utilize the RPE elevation map. Now, RPE elevation is a surrogate for drusen. So what these central hotspots are identifying are pockets of drusen. Now, looking at color fundus photographs from 2019, we clearly see that this patient has an increased drusen load currently than she did 5 years prior. But how quickly is this patient changing over time? If we look at just an isolated B scan, the exact same plane 5 years apart, we can clearly see the increased drusen area and overall drusen height. The other important or interesting piece to notice here is look at the choroidal thickness in the 2019 image versus the 2024 image. There seems to be a reduction in the choroidal thickness over time. Looking at the left eye, again, 5 years apart, this increase in drusen load and decrease in choroidal thickness. But how can we quantify that change over time? In utilizing the RPE elevation, we can look at the offset volume in either a 5 mm circle or a 3 mm circle centered on the center of the fovea, and we can evaluate the drusen volume in millimeters cubed in the right and left eye and look at that change over time. Now, what we see over time is an overall increase in drusen volume in each eye that is objectively documented. One thing to keep in mind as we're using this tool is that the scale is not always identical between the eyes. So as we're trying to compare which eye is progressing more quickly, keep that in mind as the scale may be very different between the two eyes. Now, this patient also has primary open-angle glaucoma. So what is the impact of her macular degeneration on the overall evaluation of her potential progression of glaucomatous optic neuropathy? Now, utilizing structural and functional imaging, what we see is in the right eye and in the left eye that there is decrease in the ganglion cell inner plexiform layer. Now, this is not in a characteristic glaucomatous pattern. So how can we determine, is this change in the GCIPL due to macular degeneration progression or glaucomatous progression? When we look at the retinal nerve fiber layer, there is no significant change in the right or the left eye over time. And when we look at the functional analysis, the guided progression analysis of this patient's visual fields, there is no significant change over time. So in looking at the totality of the data, it seems that this GCIPL progression is solely related to this patient's macular degeneration progression, meaning that this patient's target pressure in the management of their glaucoma seems to be reasonable for their disease state. It's important to keep in mind the impact of a patient's macular pathology on your evaluation of their other ocular pathology.